Good afternoon. My name is Dorcas. I'll be taking you through the basics that you need to consider when you're making decisions for metacarpal fractures. So it will be very basic. This will be the agenda. We'll try and look at the relevant anatomy, the incidents, salient clinical features, and the principles we need to use for metacarpal fracture treatment. Swanson in 1970 said that hand fractures are complicated by deformity if not treated, stiffness if over-treated, and both if poorly treated. The importance of the metacarpal fractures, of the metacarpal bones, is that they articulate between the carpal bones and your digital bones, your phalanges. So in that way, they help to transmit the force between the fingers and the wrist. They're also very important in terms of grip, and we will discuss this a little bit more. So the metacarpal bones are short tubular bones, and they're concave in shape. The convex side is on the dorsal side, and the concave side is on the volar side. Each bone forms an individual longitudinal arc, and when they are combined, they form transverse arches, one proximal and one distal. This is important because when combined, what it does is it allows for cupping of the hand, which is very important with the different grips that we try to make using the hand. In terms of articulation, there's an articulation proximally and distally between the carpal metacarpal and the metacarpal phalangeal joints. Why it's important to understand this is because the more motion the bones have, the more likely it will accept a little bit more angulation. So if you look at the second and third metacarpal, they're more rigidly interdigitated, and there are tendons inserting on them, so they're a bit more stiff compared to the fourth and the fifth metacarpals, which are a bit more mobile, hence they have more sagittal motion. The other thing we need to understand is the shape of the metacarpal head, that it's cam-shaped, means that the phalanx travels a longer distance when it's flexing. And why this is important, the previous lecture has alluded to this with the phalanges, is that let me use the pointer. The collateral proper is in full length or stretched when flexed, and it's short in extension. That means if we immobilize in extension and it shortens, we end up with stiffness. So the ideal position to immobilize the metacarpal phalangeal joint is with the proper collateral ligament in full length. The accessory one is not too affected because it's more volar. Then you have the volar plates, which prevent hyperextension, and they are joined with the deep transverse metacarpal ligament, which prevents proximal displacement of the fractures. The forces acting on the carpal bones, on the convex side, which is dorsal, is the extensor tendons, and this is a tensile force. And on the volar side is a compression force generated by the interosseous muscles, and this force is stronger than what is being generated on the dorsal side, and this is why we end up with a dorsal angulation of the metacarpal fractures. And the last point is why, again, we need to immobilize the limb in flexion, because when you flex, you relax the interosseous, hence you take away one of the deforming forces. It's the most common fracture in the hand, especially in young males, and more so the metacarpal neck, and we'll see why, and again more so the little finger. The mechanism of injury could be direct blow or axial loading, a rotation force, or high energy injuries. It's important to make sure you've ruled out other associated injuries and do not miss a compartment syndrome. When you approach the patient, the basics remain the same. Take a good history, examine the patient well. If you have a multiply injured patient, make sure you apply the ATLS protocol. But specifically for the metacarpal fractures, what we need to look at is, first thing you may notice is loss of the knuckle, which is an indication there is shortening. And when there is shortening, you may end up with an extensor lag or loss of power grip, because when you change the length of any muscle or tendon, it's not able to generate the appropriate amount of force. Then the dorsal prominence, which is as a result of angulation, and there may be rotation, easily missed if you examine in extension, best seen when the fingers are flexed. You'll see a bit of scissoring. Then make sure you assess for the other related soft tissue injuries. This combines several papers. Strauch looked at cadaveric studies, and he said with 2 millimeters of shortening, you end up with 7 degrees of an extensor lag. Now, what you have to remember is most of us have a 21-degree extension, hyperextension of the metacarpal phalangeal joint. So if we lose every 2 millimeters, second 2 millimeters will take us to 14, and the third 2 millimeters will take us to 21 degrees, which will bring us to neutral. Hence, you won't lose a lot of function. And that's why in this study, they concluded that up to 6 millimeters is what's acceptable. In terms of the intrinsic muscle, 2 millimeters, you lose 8%. And what was deemed acceptable for most people is about 5 millimeters. So in summary, what you can tolerate for most of us without losing significant function is about 3 to 5 millimeters of shortening. When there's an angulation, the metacarpal phalangeal joint hyperextends to compensate. And the problem with this is when there's a hyperextension at the metacarpal phalangeal joint, you don't generate enough force at the interphalangeal joint, resulting in a bit of a pseudo-claw. Rotation, like the phalanges, is not accepted at all. As we alluded to it, because the medial 2 digits are a bit more mobile, what you accept in terms of angulation is a little bit more, and the area that's closer to the joint accepts also a little bit more angulation compared to away from the joint. Imaging, X-rays, AP lateral at the bare minimum, then you can do other special views. CT scans are only necessary for complex fractures, interarticular fractures, or fracture dislocations. So as orthopedic surgeons, we know this very well. One view is never adequate. For classifications, there are many depending on which bone you're looking at. There's an AO classification, but most of the time we end up using a descriptive or location-based classification. When you are planning the management, the AO principles always apply, whether you're going to do non-operative or operative management. So reduce, stabilize, preserve soft tissue, because you're not only aiming for fixation or stabilization, you want the bone to heal, and then you want the patient to have function. So this is a busy table, but I'll try to break it down because I think it summarizes some of the things we really consider when we are trying to decide what to do with our patients. So if you can just break it down a little bit. Maybe I give an example. 3 weeks ago, we were in the trauma unit, and we had a patient with a metacarpal fracture. We thought it was a good case for intramedullary screw. So we told the patient, but then a few minutes later, they come back, and they're like, we can't afford. So the nurse asks, can you do K-wires? We said, okay. So you have to understand the principles. So if you have to change management, you know you're still changing for the best of the patient. So make sure you choose your patients correctly, who is right for operative management, who will be suitable for non-operative management. Most of the studies show that in terms of grip strength, there is no difference. In terms of range of motion, there is not much difference. In terms of complication, hardware-related complication and infection is more in operative management, and in non-operative management, it's more of aesthetics. For sick leave, it's longer in the operated patients than in the non-operated patients. For shortening, slightly more, but still within what's acceptable in the non-operated patients. And cost, much lower in the non-operated patients, and patient satisfaction is almost the same in the two patients. Splinting and rehabilitation, very critical to ensure that the patient function is restored. Make sure you get the splinting position right, whether you're doing it as a non-operative option or after surgery. Get the duration of splintage right, and initiate early appropriate physiotherapy. So the options of what you can do in orthopedics are many. These are just some of the options we'll look at for metacarpal head. Very many options. When you look at the studies again, for the metacarpal neck and shaft fractures, which is what has been looked at a lot, most of the outcomes are the same for both non-operative and operative management. Operative management options for the neck of metacarpal fractures, again, are many. Different studies trying to assess the different options. This one, they tried to assess between intramedullary and K-wires. Why the owners of this study put this lock just to prevent migration of the K-wires. These are just different studies. This one shows that actually the fifth metacarpal has the widest canal. So when you're choosing the screw, make sure you have the right size of screw, and it also has the thinnest cortical thickness, hence likely to fracture. There are bioabsorbable options. In terms of metacarpal base fractures, you have to mention the Bennett's, the Rolando, the reverse Bennett's. So I didn't discuss the specific management because the topic is wide. We just wanted to look at the principles that will guide the management. So in summary, focus on the principles: early mobilization, individual judgment for each case, consider the fracture personality, make sure we are restoring function, not just union, and minimize complications. These are my references. Thank you.